begin our lectures once again. For this afternoon's lecture, it's my pleasure to invite our guest, Dr. Alfonso Garcia. Dr. Alfonso Garcia is a spine surgeon at Espalda Saludable at Tijuana in Mexico. Dr. Garcia has contributed to endoscopic spine field, having participated and collaborated as a writer for several chapters in 3 major endoscopic spine surgery textbooks. He's one of the leading endoscopic spine surgeons in Mexico and will join us today to give us more information on posterior cervical endoscopic approach. Thank you for being with us today, Dr. Alfonso. Now I leave the world with you.
Thank you. Thank you for having me. So as mentioned earlier, this afternoon, we're going to talk about posterior endoscopic cervical approach using the single working channel scope. And we are going to do a step-by-step means. This is my disclosure. And it is very important to highlight some of the background that needed to happen before we were able to perform a full endoscopic foraminal approach for the cervical segment. So since the late 40s, that means with Mixter in 1950, the posterior cervical approach for herniated disc became popular. And later on, until 2008, a full endoscopic cervical foraminotomy was performed in Germany by Dr. Rutten. Before that, a little bit before that, Dr. Foley used the tubular retractors in the same means to perform this same procedure. And currently, I've been following closely works by Dr. Nishimura, Dr. Shen, Dr. Carr, Dr. Hofstetter, which are the leading surgeons who perform this procedure. So this evening or this afternoon, we're going to talk about 2 basic techniques. One is actually an extended approach of the first. The first is the posterior endoscopic cervical discectomy. And the second one is the cervical endoscopic unilateral laminotomy for bilateral decompression. So recommendations for surgeons who are starting with endoscopic techniques is that this is an advanced technique in endoscopic spine surgery. This means that it is qualified for experience with conventional and MISS posterior cervical approaches. You have to go through a basic training in endoscopic spine surgery. You have to be very familiar with the lumbar endoscopic interlaminar approach and feel comfortable with the lumbar transforaminal endoscopic approach. The last 2 will train you for instrument handling because the interlaminar approach is very unstable. So that means that your scope might move through a wide area, anatomical area, and you won't be able to pinpoint the exact location where you need to do the decompression. So it is very important to be first familiarized with the interlaminar approach. As you can see, there are many types of burrs to get the bony work done. And you have to be aware of when to use each and every one of them. So some anatomic considerations for the posterior cervical spine is that the lamina actually continue to the facet joints, and the facet joints are laying one on top of the other, as you see in the drawing right there. So in order to get to the foramen, as we saw earlier, there are many ways of getting into the foramen, but the objective is to conserve as much bone as possible. So you can do an inclinatory laminotomy way of accessing the foramen, or you can take some of the lamina in order to open the posterior foramen. That will depend on the dexterity of the surgeon, the ability of the surgeon, and the pathology itself. So I like this drawing very much because it's a little bit transparent and it lets you, the viewer, identify where the exiting nerve root is underneath the bony structures. I like this work just recently published in 2021. And basically what it says, it describes the surgical critical width. And basically it outlines strategic differences between the younger patient and the older patient. What it means is that in the older patient, between levels C5, 6, C6, and C7, the actual lateral limit of the dura is a little bit wider in relationship to the V point. This is very important because the V point is your anatomical landing part that you need to identify before you start decompressing. And you need to know that in the younger patient between 40 and 50 years old, this dural sac is not that wide. So you can go a little bit lateral to the V point, and you'll end up addressing the lateral part of the dural sac. In the older patient, you will have to drill a little bit lateral to the V point because the widening of the dural sac. So this is depicted here in this comparative picture. In the younger patient, the V point is almost in close relationship to the lateral part of the dural sac, and in the older patient, the V point stands medial to the lateral portion of the dural sac. So for instruments, there are many scopes that can accomplish this task. You need to know what kind of scope will better perform for this approach. So depending on the scope you're using, it is always keen to know what is the angle of your lens, what is the working length, what is the diameter of your working channel, and what type of instruments will better perform with the scopes you're going to use. In one of the available scopes that we have, this company has, is 3 scopes to address the cervical spine. I personally like to use one with the smallest outer diameter, but the largest working channel, which is called in this picture, the Elysis Pro, which has a 7.3 outer diameter with a 4.7 working channel. That means that I can use a 4.5 burr, which is a fairly large burr, to do the bony work really fast. So the OR arrangement, the equipment and team, I like to use the arrangement that you have been seeing throughout the live surgeries. I like to keep my scope to my right, the fluoro monitors to my left, always depending on the side I'm addressing, but I'm keeping my video to my right always. And the C-arm goes at the level I will be working. Obviously, I know that there are many variables depending on the size of your OR, but this is the basic way I use my setup for the OR. So step 1 is patient position. Obviously, the patient is prone, and you mark the level. You use the C-arm to identify the level of surgery. And what I do is I try to place my needle parallel to the inferior part of the body, so I can better identify the direction I'm going to follow with my scope. So I confirm my needle placement in 2 planes. You don't have to use necessarily a needle, just a metal marking, and that will be enough, because once you're there, you can use your scope or your cannula to retarget and recenter. So once you're there, you have to decide whether you're going to do a transverse or a longitudinal incision. I prefer to use a transverse incision because it's more anatomical, and rarely I use a longitudinal incision, depending if I need to go 1 or more levels upward. But single incision, transverse incision works very well. So step 3 is to, step 3 is to incise superficial and deep fascia. These are very strong fascia, so be aware that once you incise the skin, and I use a Kelly Rongura hemostat, and I touch the superficial fascia. I don't perforate it with the Kelly, I use the knife, and then I go again with the Kelly to separate muscle fibers until I reach the deep fascia, and then I incise the fascia again using the knife. I try to follow the oblique direction of the muscle fibers in order to cut as less as possible and maybe just separate muscle fibers. So this is how it looks when you incise the deep fascia, and just be aware of how the fibers are oblique. So I need to remind you in step 4 to incise both superficial and deep fascia. Follow the directions of the muscle fibers until you reach bone, and be aware of the deep insertions of the muscles you will find, which is the semispinals and the multifidus muscles. Once you separate the fibers for those muscles, you will reach bone, and you have to touch the inferior edge or border of the superior lamina, and that is more than enough. Come again, I use the Kelly hemostat because it has a non-traumatic tip, which I can palpate the bone very well and very safely. And then I'll take x-ray just to be sure that I'm on the right level. And then afterwards, I will use the sequential dilators until I put the cannula. In this case, you can see there's a mechanical arm, which I used in my very first cases because I wanted to keep a very stable hand, and the arm helped me. So I tried to keep a little bit loose the cannula so I could move the cannula, but still keep a firm grip. Now I don't use mechanical arm. I only use cannula, and I use my hand, my steady hand. So once you're there, you remove a little bit of soft tissue, and you get to bone. You identify the inferior edge of the lamina, the superior edge of the inferior lamina, the V point, and then you start drilling. So if you're going to do just single side, single level laminoforaminotomy, you drill about an 8 millimeter drill hole, depending on the type of laminotomy you're going to do. We just saw earlier in the talks that inclinatory laminotomy conserves more bone, and I do recommend this as a next level. But if you're using a laminotomy just for single level, be aware not to resect too much lamina. And if you're going to extend the approach to the contralateral side, you just go and follow the inferior edge of the lamina until you go to the contralateral side, and do exactly the same with the inferior lamina. Okay, so once you're there, you identify the nerve root, the pedicle, and you mobilize the nerve root and perform the fragmentectomy or resect the osteophyte. And if you need to extend the approach, just be aware to keep medial to the pedicle in order to avoid the artery, and that will keep it safe. And for the end point, take picture and record every step of the decompression. So I have a video of 2 case examples I'd like to share with you. So this is the first case. It's a discectomy, a C6, C7, right, a herniated disc. This was my first posterior laminoforaminotomy, cervical. So the intra-op fluoroscopy with the cannula in position, the initial dissection, the initial drilling of the inferior edge of lamina for C6. I try to leave the anterior cortical intact in order to resect it with kerosene rongeur. As you can see there, I find it that is more safe to do it manually than mechanically. Nowadays, I can do both because I feel more comfortable with the approach. But initially, I used to do it until I reach that anterior cortical, and I would do the rest with the kerosene rongeur. So we see some of the yellow ligament there and the superior edge of C7. I'm start to drilling there. As you can see, I left the anterior cortical of the lamina of C7 intact. So I'll take some bites. And you can see how the yellow ligament is very shyly attached to the inferior lamina, and when you remove bone, it immediately detaches from the inferior part. I'm removing the herniated disc. You can see part of the pedicle there on the left side of your screen. I will let you know where it is. And as you can see, it is very decent and very pairing with the nerve root because I don't have to use any retractors. You see the pedicle right there and the nerve root completely decompressed. Almost no bleeding. There's a nerve root, the pedicle, cephalad, caudal, lateral, and medial. So fully decompressed. This is the amount of disc removed. And the post-op fully decompressed MRI. Patient did very well. 4 hours after the surgery, patient was symptom-free, and she left the hospital the next day. So the next case, it's a cervical endoscopic unilateral laminotomy with bilateral decompression. It was a C3, C4, and C4-5. As you will see in the pre-op CT scan, this patient had a PLL, OPLL, I'm sorry, and he was myelopathic. You can see severely 2 levels compressed, C4-5, C3-4, and this is the anatomical representation of the levels we're going to treat. So this is the initial view of C3-4, and you're going to see me dissect past the midline before I even start drilling the bone. This will facilitate going to the contralateral side. I'm already there midline. You can see the flavum there, how it folds in the midline. So I'm going to two-level decompression with 1 incision on one side. So I'm drilling the inferior edge of C3. And I'm leaving as much of the ligamentum flavum intact to use it to protect while I'm drilling. So I'm removing what's left of the lamina. And as you can see, I'm keeping the ligamentum flavum, which is already detached from the upper part. I'm going to start working on the superior edge of the inferior lamina. As you can see, the flavum is already detached. So in this level, I took it out completely, almost in one piece. So I only had to remove this little part, and that's a complete decompression of the C3, C4 level with starting on one side and going over the top to do a bilateral decompression. So we're going to do a sliding technique. You see the lamina of C4, and we're going to repeat exactly the same steps at C4-5, identifying the V point, dissecting past the midline, controlling the bleeding, and then to start drilling again at the inferior edge of C4 and following the bone drilling to the contralateral side. And in this level, I couldn't remove the flavum in one piece. So I'm removing the contralateral part of the flavum, a little bit of lamina that's left, and a fully decompressed C4-5 level. And as you can see what's left of C4 lamina, I will show you. There it is. And both levels decompress through one incision. Almost no bleeding. Very small patch. 3 hours of surgery. Again, this was my first double level and bilateral decompression. Patient left next day, and for the first 3 months, he started to regain his arm movement and strength. He still wasn't able to walk until 6 months. So I have very little experience, only 5 patients with 7 levels. And recently I haven't added a 6th patient I operated other 2 levels. So in total, I have 6 patients with 9 levels addressed. Mean age is 63 with a JOA score of 10.2 initially, a JOA, post-op JOA of 15 with a mean surgical time of 74 minutes. I don't have any complications up until now. And days of hospital stay is only 1. So compared with more experienced published papers with as like those published with Dr. Nashimura, Dr. Shen, or Dr. Carr, my results are very similar, and I hope to keep gaining more experience as I address more and more cases like this. So it's still a noble technique. It is still improvement. There's still a lot of room for improvement. We need more publications on this part of our country. And I find it very promising, which shows very few complications. Of course, definitely minimal tissue disruption, and it offers very short hospital stay. This is where you can contact me, and I will be waiting for any emails from you and any other questions. And again, I thank all the organizing committee, and a very, very, very special thanks to my mentor, Dr. Gunchoy. I miss you. I miss Woody Dule Hospital, and big hug to all the nursing team and the hospital staff at Woody Hospital.
Thank you so much for your kind words and for your wonderful presentation today with us, Dr. Alfonso. We had a great insight on how to approach right now the posterior cervical through endoscopic spine surgery. We thank you once again, and we'll now continue. As we don't have any questions from our viewers right now, we'll continue with today's presentations. Thank you very much once again.